Welcome everyone. Thank you for coming to listen to our talk on genetics. So my name's Emma. I work in cancer genetics and I'll be presenting with my colleague Sally who works in general and prenatal genetics. So we're going to go through a bit of genetics in terms of inheritance modes and also different clinical scenarios. So here are a few of the learning objectives to be able to understand the importance of genetic counselling and to be able to describe clinical scenarios in which genetic counselling would be useful, and also to be able to outline what's involved in genetic counselling and how do genetic services make risk assessments for their patients, and describe the features of a family history which may suggest an inherited pattern of disease. So just to give you a little bit of background on genetic counselling is a service that provides information to families where there may be a genetic diagnosis or a familial trend of disease within a family, and it's about being able to provide that family with information to adapt to the condition and information on recurrence risks if they're going to have further children, and information for relatives as well so that they are aware of the risks that they may be facing and that they can get the appropriate medical management that's required for that. A big part of the role is providing education on how conditions are inherited so that patients have a good understanding of what they need to then inform their family members and just how that they can adjust to that diagnosis. And a big part of it's also the psychosocial aspects of providing supportive counselling and being able to help them if there's decision making regarding whether or not to continue a pregnancy or whether to have surgical intervention for a particular risk. So just to go through some of the stages of genetic counselling, who is referred or who refers to us? So we are a quaternary service, so we encourage specialists to refer. So a big part of the referrers for our service are medical oncologists and surgeons. And in obviously the general setting, you'd have a lot of obstetrics and gynecology staff and paediatricians refer on. GPs also are big referrers for our services, and a number of patients will contact the service themselves because they're concerned about their own health issues, their family history. Media often prompts people's calls as well. There's been obviously many years now a lot more media attention around genetic conditions. And other health professionals that we may get referrals from, I guess in my setting, I'm thinking more of people like the breast care nurses who regularly assess for family history of breast cancer. They may be people who refer on to us. And obviously in the prenatal setting, the midwives obviously ask routine questions as well about family history. So there's different, I guess, referral concerns that people have, and there are people who want advice about reproductive issues. That may be because they're aware they're a carrier of a condition. They may be aware that there's an affected member in the family, a cousin, and they want to know whether they are a carrier and whether there's reproductive implications for them and their partner. There may be paediatric concerns that their child's not developing as they should be with their particular milestones. There may be dysmorphic features, other health issues that there are concerns for, and obviously we'll go into more of these particular clinical conditions. And then there's adult onset diseases which can come on later, like some of the musculoskeletal conditions or conditions like Huntington's. So the first part of our appointment usually involves taking a detailed family pedigree. So we usually try and get 3 generations. It's really important, obviously in the prenatal setting, to get any pregnancy history, whether there's been any miscarriages or fetal losses. You're looking at also things like ethnicity, whether there's, you may know of particular gene mutations that have a higher population frequency within a particular ethnic group. And there's also consanguinity is something that's important to ask about, because if people are related to each other and there is a known genetic condition in their family, then there's obviously higher concern that both of the parents may be carriers. So part of the importance of taking a pedigree is that it provides us with a really good opportunity to build rapport and get a really good understanding of the family dynamics and what's already understood about the health history within a family. And it can identify too, if we've got a condition that we're concerned, we may find a clinical diagnosis for who else in the family may be at additional risk. And I guess as well, looking at those different family communication dynamics, and that becomes an important part of our work if we're going to be seeing further relatives, and we're encouraging individuals to pass this important information on to their relatives. We need to obviously have an understanding of who they're in contact with, what are their concerns if they're going to be passing this information on. And I guess from a medical point of view, most importantly, it's a very good visual aid for us to look and see a particular trend and make a clear assessment. We're involved with clinical genetics staff. Now in Wollongong we don't have anyone on site, but up in Sydney we have clinical geneticists who service our population, and they come down and run clinics, whether it's once a fortnight or once a month, and so they're involved a lot of the time in also providing advice on the assessment. And then we make a plan of action of what's important next. Do we need to get further medical investigations? Do we need to confirm some of the diagnoses? Do we need to go on straight to ordering genetic testing? A big part of the job, as I said before, was providing information and support to patients. And so looking at sort of the family and personal stresses, how they're potentially adjusting to the particular diagnosis, what are their concerns, and what resources can we help with, whether it's information, linking them in with other families who are in a similar situation for extra support, or a counselling service to, I guess, whether they've just lost a relative due to a genetic condition and need grief-related counselling, or whether it's chronic sort of stress in the family from a long-term developmental issue within a family that they need sort of that, I guess, extra support with. Obviously a big part of our role is coordinating genetic testing to find a diagnosis, and it's really important to gain informed consent from our patients regarding that. And part of that consent process as well, it's quite important that we ask about if this information does reveal a genetic condition, is that information able to be used for the benefit of the health, sort of making an assessment for your relatives. And so most people are very happy for that, and they're often motivated by wanting to make sure, you know, that it's information that their siblings, nieces, nephews, children can benefit from. Most of the testing is publicly funded. Some of the testing is covered through Medicare item numbers specifically, and other testing is covered by department funding that clinical genetic services have. Obviously there are some testing that, if I guess it's not considered clinically necessary, then it's not publicly funded, but patients may still wish to pursue that at their own cost. And sometimes we are involved in facilitating that. Unfortunately, it is becoming quite a demand in our service with cancer genetics that a lot of people are very interested in BRCA testing, despite there potentially being a very low risk for those individuals. Now, the genetic testing can involve looking at chromosomes, it can involve looking at single genes, or doing panels related to a particular condition, whether that's, say, a cardiac panel, where you're testing a number of different genes that can have an implication for a heart condition within a family. And I guess the testing is important either to confirm a clinical diagnosis, so a person has a clinical condition that we're trying to find the exact cause for, or it may be that they're a relative who's a healthy person, but we want to see whether they potentially also may be at risk of developing this condition in the future, whether that's Huntington's or it might be, say, for a BRCA fault, they may be at a high risk of cancer, or it may be assessing whether they're a carrier of a recessive gene mutation so that they have that information for reproductive decision making. Obviously, the follow-up, a main part of that is to provide management advice. Usually we're not providing the actual management itself, we're sort of helping to coordinate with multidisciplinary teams so that that patient can have further follow-up with whoever is appropriate to look after them. And then we're involved in seeing the family members to provide that cascade testing, or what I sort of called predictive testing before. So that can involve obviously to see whether they're carriers of a condition that they may not be at risk of but may need for reproductive decision making, or if they're potentially at risk of a later adult onset condition. I'll finish with this slide and then I'll let Sally take over. But this is just, I guess, giving a good summary of what are the different genetic counselling services. This doesn't, unfortunately, cover every single scenario, but it's the main ones that are services that are provided. So there's cancer genetic counselling, prenatal. Part of that obviously involves preconception and pre-implantation genetic diagnosis sort of counselling through the IVF process. There's a particular statewide service called the Genetics of Learning Disorders. There's specific cardiac genetic clinics, and there's clinics that are specific for neurogenetics. And obviously, as part of that genomic testing, where they're now doing more thorough testing and looking at whole genomes or whole exomes, sort of is something that's been considered in a number of those fields.
So I'm going to give you a little brief rundown on the general genetic counselling. So I'm here at Wollongong Hospital as a general genetic counsellor and work a bit in prenatal as well. And I thought the best way would be just to go through some of the inheritance patterns, so it might bring me back to uni years. But 2 to 3% of babies are born with a major congenital anomaly or an intellectual disability or a lethal disorder. And so when we look at that, we are considering, well, is there a genetic cause for that birth defect? And in this pie graph here, you'll see that the majority is unknown. That's the big yellow one. We don't know the cause, but we can have causes that are chromosomal, so we're talking about things like Down syndrome, or maybe some microdeletion syndromes that you'll hear of. There can be prenatal exposure, so that's non-genetic, but they're sort of the teratogens that you might find through medications or infections. There's single gene disorders, which is saying 2 to 10%, and we'll go through a little bit of those, and they're the ones that are the Mendelian inherited. And then there's the bigger chunk, which is often multifactorial, so you're thinking about your cardiacs, your diabetes and things like that might have a genetic component, autism, but we don't have a pinpoint exact gene. So the known genetic conditions, the main one that we all know about is chromosomes. So we all remember this picture of a karyotype. And what we're talking about with a chromosome condition is often Down syndrome or trisomy 21. And that's caused by having an extra chromosome 21. As you can see that's circled, there's 3 copies of the chromosomes. So we all know we all have 2 copies of all our chromosomes, one from mum, one from dad. They're numbered 1 down to 22, and then we have our sex chromosomes. And in this picture here, is that a boy or a girl's chromosomes? It's a girl, because it's 2 X's, and if it was an X and a Y, then it'll be a boy. In this case, it is Down syndrome, as we said, because there's a extra copy of chromosome 21. For most chromosome problems, if it's just caused by a standard trisomy, so having a complete extra chromosome, it's what we say is via non-disjunction. The recurrence risk for any family is low, it's usually less than 1%. But if there's a family that has a translocation, so that the change in the chromosome is caused by a translocation, the risk is much higher, and so it's important for us to know what the causes are. So I've got a picture here, it's hard to see over here, so we might just look at this one if that's alright, which shows, in this case it's a lovely balanced translocation, so this person will be well and healthy because they've got the right number of chromosomes, the balance is there. But you'll see that this part here, this white, has a tiny bit of red down the bottom, and it's swapped here. So between 22 and chromosome 9, there's been a translocation where that has swapped places. And when they go to have children, we only pass on one set of all our chromosomes, and if they pass on one of these translocated sets but not the other, that child will have an unbalanced set of chromosomes, and that can cause a significant problem. And that can happen again and again because that parent actually carries that and it's been inherited. Then we've got our Mendelian inheritance, so our single gene disorders, and we're starting with autosomal dominant. Do we know what that means? So all our genes come in pairs, just like our chromosomes, and if we have one that is faulty, that actually causes the disease. So even though there's a working copy on the other allele, just having the one fault is sufficient enough to have the condition. What that can happen is it can be what we call de novo, so that means it's occurred for the first time in that child. And so for those parents, the chance of it happening again is actually quite low, but for that child themselves, there's a 50-50 every time they pass it on. So if a parent is affected, it's 50-50. So here's a picture here. Does anyone know this condition by any chance? It's relatively common.
One lady has.
One of
This lady has.
Is it Turner's?
No, good guess though. It's Noonan's. So Turner's does have, it's a chromosomal Turner's, so it has one X chromosome, and they've got the webbing of the neck, and you often see that with Noonan's as well, so that's a good pickup in that sense. So often when we see during pregnancies, if there's extra fluid at the back of the neck, it can be one of the differentials is Noonan syndrome. The hairline is often quite thick and lower at the back of the neck. They tend to have eyes that are a little bit further apart, but it's quite variable as well, and there's often a cardiac involvement. We do see Noonan's where it can be more severe to quite mild, and it is that 50-50 passed on. And this one's a classic picture of twin boys. Are they identical or non-identical? We're going to say they're non-identical because one of them has a gene fault that causes achondroplasia, the other. So that's a classic 50-50 risk. So here is a pedigree that we'll look at for a dominant inheritance, and basically what you're seeing is that it is a vertical transmission. It's 50-50 all the time, it's passed down. Okay. So what we see is this is Huntington's disease. The grandma up here had the condition. She had 4 children. She passed it on to 2 of them. Only those that got the gene fault can pass it on. The ones that don't have the gene fault can't pass it on. Okay? But then you can get lovely pedigrees that look like this one. And this is a cancer family, BRCA, which is also a gene, a dominant gene. So if you have it, you have an increased risk of developing cancer. But not everyone will get cancer. So in this case, grandma had it. She passed on to her daughter. Doesn't look like her son has anything there. And we don't have any more. That's not a very good picture.
Yeah, that's not a good picture.
What we might see is that one of these ones actually are at risk of cancer, because even though their father did not have cancer, he could still have the gene running in his family, so from the family, carrying the gene fault and then potentially pass it on. We call that incomplete penetrance, where you actually see, even though the picture doesn't look like it's been passed on exactly, if the gene fault has that's the underlying cause is passed on, you still can be at risk as a child. Does that kind of make sense? I didn't really look at that pedigree before we talked about that.
Yeah.
Another one is recessive inheritance. So what does that mean? Yes. We need both copies of the gene. We need the double hit to be faulty in order to have the disease. And the classic one that we often know about is cystic fibrosis. So 1 in 25 of us are carriers. Carriers are well and healthy. They don't show any signs or symptoms, but they have one faulty copy, one working copy of the gene. But if you get the double hit, then you have the disease. If both parents are carriers, then the chance of having a child is 1 in 4 that will be affected, or 25%. And this picture here, I'm not sure if anyone recognises from the media who this might be. This is Mackenzie. She's a little girl who had spinal muscular atrophy, or SMA, and she's been quite in the media because her parents have been advocating for preconception genetic screening because they were both carriers of SMA and did not know until she was born. So that's something that's been quite present in the media at the moment. If only one parent is a carrier of a condition and we screen the other parent and they're not identified as a carrier, then the chance of them having an affected child is actually very low. We never say 0 though, because our screening is never 100%. So a family for recessive inheritance looks like this. We've got little dots inside to say that they're carriers. That means they're not showing any signs or symptoms, but they do have one faulty copy. And it can run through many, many generations, but it only presents as a condition once both parents are carriers. So it's got to come from both sides of the family. And in this case, as you see, they've had 4 children. We say it's 1 in 4, but it's not one in every 4 pregnancies. It's in every pregnancy, the chance is 1 in 4. So you might have someone who has 4 kids who all 4 are affected, but they just got unlucky with their 1 in 4 chance. This case, it was 2. The other one is X-linked recessive. Does anyone guess how that's inherited? By the mother. Yeah, good. So it's via the X chromosome. So, and this would be politically incorrect to put on a recording, but obviously females are more superior because we've got 2 copies of our X. So if we have a faulty one, we've got a backup copy, we're fine. But it's the poor males who have 1 X copy, and if they have a fault in that gene, they will be affected with the condition. So that's the problem. So the big one that we often hear about is Fragile X. And so that's the most commonest cause of inherited intellectual disability, and it's a fault on the X chromosome. And here's just an interesting one to show another one, which is a dry skin scaly condition called ichthyosis, so X-linked ichthyosis, where mothers are carriers and they pass it on to their affected sons. So a family tree would look a bit like this, where you see only the males are affected, that's why the squares are coloured in, and the circles of females are carriers. What's unique about a family tree when we look at X-linked is that mothers can pass on to affected sons, mothers can have carrier daughters, but affected sons will have carrier daughters, all of them, but they can't pass it on to their sons because they pass on their Y chromosome to their son, which makes them a boy. So in a family history like this, there'd be no male-to-male transmission. Then we've got mitochondrial inheritance. Has anyone heard about that? So basically we have most of our genetic information is in the nucleus, and that's part of those chromosomes that we talked about. We also have a few genes, a bit more than a few, in the mitochondria, and that's passed on only through the mothers. It's maternally inherited. So all the mitochondria is inherited from mum and none from dad. So what we'll see in a family history like that is that mum will pass it on to all her children, but any man who has it, none of his children will have it. Okay? So the picture before, if I just go back, is a picture of, because we're trying to decide one to show you as a picture. Most of them are multi-system, and you might see things that are sort of, with strokes and encephalopathies and all those type of things, so I couldn't find a nice picture for that. But this is Leber's, and you can see it's a vision problem. So what you're seeing is that the vision would look like that if you had that condition. Then we've got the multifactorial, which was that big chunk of what we look at conditions that cause birth defects, 20 to 25%. And they're things that you're talking about like cleft lip and palate, neural tube defects, or as we're getting older, things like the increased risk for cancer or cardiovascular, metabolic things like diabetes, and then all your neurological things like schizophrenia, Alzheimer's, things like that as well. Oh, that's just a nice little comprehensive list. This is just a way to sort of describe how you think about multifactorial. It's often multiple genes plus a bit of environment, and it's a combination that you get inherited from a parent that might actually get you to present with that disease. So here we see there's mum and dad, and the cup of the genes that might predispose to a condition. Say this is autism, this is a good one. That you've got to reach the threshold up the top to actually present with the condition. Dad doesn't have enough, mum doesn't have enough, but when they pass them on to their children, you see this one seemed to get a lot of those genetic predispositions and has enough to hit that threshold, so that child would have autism. But this one didn't get very much of it, no features. This one got some, but again, not enough to have the condition. And this one got a different ones to that one, and they have autism. Does that kind of make sense? It's very hard to say, it's very complex, we don't have single genes, it just seems like a combination, interaction, and something that we're just not there yet in truly understanding how to interpret. So, by now you're probably nearly asleep, so we thought we'd ask you a question, just to keep you awake and alert. Here's a pedigree. It's the inheritance. Anyone want to take a guess? We've even given you some answers. So A, could it be a recessive condition? What makes you think it could be?
So it
Could
should
be
be.
It can't be
It can't be excellent. Why not?
because they're males.
Because it went from male to male, that's right. So it's kind of tricky because only males are affected in this pedigree. So you could have went, oh, it's excellent because only males, no females are affected. But because it's
Is it
male-to-male
mitochondrial?
transmission,
But you don't know who
Who
in the
they're
middle
having-
line, who they're having
Babies with.
relations with.
well, presumably it's
One
women of the
parent.
opposite sex. So
Yeah,
if
but
that's
like-
another
So obviously all the other people aren't affected.
yeah.
The partners aren't affected.
Because we're looking at how it is, yeah, that's right.
So the
They
how
carry
they're
this.
linked, the ones that have passed.
But are we assuming
Yeah,
that
they
the
have to
blank
be.
ones aren't carriers?
Unaffected, affected. That's all.
Okay.
So it'd have to be
Because we
recessive.
don't know the carriers.
Interesting, isn't it? It's quite complex. So you're right, we've linked it and we've got our excellent. Mitochondrial, what did we say was about them?
Mothers.
Mothers. So if he was affected with a mitochondrial disorder, none of his children would be, so that one's excluded. So we're halfway there. Recessive conditions, we expect both mum and dad to be carriers, and that can be passed down through generations. We don't see any carriers, which is a little down inside in this picture. And you'll just see one child here and there that is affected, the recessive condition. So often there's no family history with a recessive condition, because you can be carriers but not show any signs or symptoms. So this is not a classic recessive history, because you're seeing it being passed on from generation to generation, irrespective of their partners, unless they all married their cousins. Yeah, so I'd say recessive probably wasn't. So what have we got left?
What is that more dominant?
Dominant. Okay, does it look like a dominant? Someone's shaking their head. How come?
Because you're skipping generations.
Because they're skipping a generation.
Like incomplete.
What does the incomplete penetrance mean? That you can have the gene fault, but you don't have the disease. So it looks like it's skipped a generation. And so a perfect example would be if this was, I'm not going to say breast cancer because they're all males affected, but
Lynch
cancer,
syndrome.
Lynch syndrome, so an inherited cancer condition is that all these males have cancer, bowel cancer, or any cancer associated with Lynch syndrome. This woman here doesn't have the cancer, but she inherited the gene fault that caused it. Has not had the cancer, but she's been able to pass it on to her children. So it's called autosomal dominant with incomplete penetrance. The last one's polygenic, which is that one we say multifactorial, polygenic, multiple genes. That could fit this picture, that when you see it being across 3 generations quite strongly, you start to think that it's more likely to be a dominant condition with incomplete penetrance. Yeah. So it's interesting, isn't it? It's quite fun to look at pedigrees and work out these things. So the other aspect that I do a lot of is prenatal genetic counselling, so I thought we could just run through quickly.
We've got 25 minutes.
Okay. Just some ideas of some prenatal aspects or reasons why you would refer for prenatal genetic counselling. So that can be because of a family history of a known genetic condition, birth defect or a developmental delay, and they're concerned about the chance of it happening again. Having an increased risk on first trimester screening or NIPT, does that sound familiar? Do you know those words? Yep. Anomalies observed on ultrasound scan, abnormal CVS or amnio result, recurrent miscarriages, or if the parental bloods indicate thalassemia is a good example, depending on your ethnicities. So the main reason we do all those first trimester screenings, etc., is because of the common trisomies. So what type of trisomies do we have? Trisomy 21, yep.
13 and 18.
13 and 18, that's right. So 13 and 18 are both potentially viable. They can survive the pregnancy, but most will not survive the full term. If they do, they usually die within the first few days of life, though some can persist for a little bit longer. But they are ones that we can know about in a pregnancy, and that's why we test and look at those. And these are 2 of the conditions, 13 and 18. Does anyone have a guess? I made it really easy.
13 and 18.
Yeah, so 13 tends to have midline problems, so you see things like clefts, etc. And then in 18s, they tend to be smaller babies, not as well grown yet, and the talipes and things are quite a classic feature. Rocker bottom feet. So we know that as we get older, the chance of having a baby with a chromosome condition like these three increases. So when by the time you hit 45, it's 1 chance in 19. So don't wait till you're 45 to have children. First trimester screening. What they're doing is actually looking at the fluid at the back of the baby's neck. And they've worked out that if it is larger than normal, kind of like in this picture, they're more likely to have a baby with chromosome problems. And they also do a blood test to look at some pregnancy hormones, and they'll give us an indication or a risk assessment on what that chance that baby has, Down syndrome, trisomy 13 or 18, based on the information that's provided, in conjunction with the mum's maternal age. Okay, so that's what they use when they're talking about that. If the nuchal is large, it could mean a chromosome problem, that's what we just said, but it also can mean other things like cardiac conditions or rare genetic syndromes like Noonan syndrome that we talked about before. One of the other tests that is available now is non-invasive prenatal testing. It's also called MIPS because it's not a diagnostic test, it's an advanced screening test. Everyone seems to know it as a Harmony test. That's the brand. But everyone will come in and they don't know what MIPS or an IPT is, but they know Harmony. So basically what they're doing in that is it's a blood test for a mum, and they can get the baby's DNA fragments are floating around in mum's bloodstream, and they're able to collect that and look at the amount that there is. And we know that if there were 2 copies of all the chromosomes, which is what we want to expect and hope, you'd expect there'd be a certain amount to be there. But if it is larger, it indicates that there is a 3rd copy of that chromosome because the loading is higher. And so they're looking at it as a quantitative analysis, but they're not having a proper look at the number of chromosomes. That's why it's not a diagnostic test. Because at the end of the day, you're drawing a line and saying if it's below this point, it's 2, if it's above, it's 3. But it is very, very good at picking up particularly trisomy 21 or Down syndrome. They say it's over 99%. You can get false positives though, so as we say, emphasise it is still a screening test. It's available from 10 weeks, it takes 5 to 7 days, and currently it's not Medicare available, so it costs over $400 for the patient out of pocket. If we're concerned about a baby having a problem, be it a genetic condition like cystic fibrosis or something that's single gene that they want to test in a pregnancy, or that there's an increased risk on those screening, or just because of advanced maternal age, you can always have diagnostic testing, and that's done by CBS, which is usually done 11 to 13 weeks of pregnancy. They test a sample of the placenta, actually look at either the DNA in the particular gene that we're worried about, or at the chromosomes in detail to see if there's any extra or missing copies or pieces of chromosome. There is a risk of miscarriage by doing that test, and it's about 1%. There is the later test as well, the amniocentesis. It's done between 15 and 19 weeks and has a slightly lower risk of miscarriage of 0.5%. It's done later in the pregnancy, so it just depends what people prefer. The last thing just to talk about, just as a summary about prenatal genetics, is obviously if we know we're at risk of a condition, we can choose to test a pregnancy, but if we find out the child is affected, the only option we have is to elect not to continue the pregnancy or continue the pregnancy knowing that the baby will have that condition. We can't fix it. And some people don't want to go through that dilemma of deciding would they have a termination or not. There is the option of having pre-implantation genetic diagnosis through IVF, and that's where you can actually do the IVF process, and when you get the embryos, they screen those embryos for whatever condition that you have in your family, and then they can put in, only transplant the ones that are known to be unaffected with that condition, and then you start that pregnancy knowing that baby will not be affected. Hopefully, because IVF never works beautifully. But if you get pregnant, that's what you're hoping for. People can do PGD because of a known condition. They know that they're carriers or there's something in the family. They can do PGD because of just looking at aneuploidy. So as we get older, we know that chance is increased. So let's just look at the chromosomes and make sure that baby does not have trisomy 13, 18 or 21. And then there is, but we don't do it unless we know there's something in the family. But now what we have is something that's called preconception screening, which is readily available in the private setting, where people are testing for common genetic conditions, and this is just an example. Cystic fibrosis, Fragile X and spinal muscular atrophy is a panel where they'll just do population with no family history just to find out are you a carrier or not. And if you are, test your partner, and if they're a carrier, then we know that you're actually at risk of that condition. But if they aren't a carrier, then the chance is low. As you can see, the risks are sort of reasonable to be a carrier. Cystic fibrosis, in every classroom, one child would be a carrier, based on statistics, 1 in 25. But you would never know unless you did a test.
So can I just ask, with the ethics about the pre-implantation genetic diagnosis,
Yeah.
is there any legislation about what you're currently allowed to choose? You know what I mean? Like, can you test for, down the line, the hair colour, eye colour,
Yeah.
sort of stuff?
We're talking about disease causing genes at this point.
Is there any legislation around
Yeah.
being able to choose other?
Like traits?
Yeah.
Yeah, no, it's really limited to disease causing. Is there legislation against that? You're not allowed to go again for a sex selection. That's
Okay.
legislated at this point. It gets brought up now and then about whether you can. Not in Australia, you can't pick sex selection. You see couples go overseas if that's the choice they make. They're pretty tight on things like that, but we don't really have genes for hair and eye colour and traits and stuff at this point. It's still more of a theoretical.
Okay.
But, everything is possible and available, and they will be sort of looked at from a legislative point of view. What we look at is anything that's disease causing at this point. Yeah. And there's just a pretty picture. They say sperm goes to egg, or via ICSI, where we actually pick the sperm. It makes an embryo. You let it grow to the day 5 blastocyst stage. You pick a cell and we do our gene testing. But the preconception testing is really in the private domain at this point. We do not offer it from a public perspective, but they're just some of the companies that offer it. And the reason why it's really come up is that Mackenzie's law of that little baby I showed you, SMA, that was born with SMA. Here's a picture. And they've really advocated strongly, and the federal government has recently approved that they're going to offer preconception screening as some money towards that and funding towards that. How it's actually going to be spent yet is still debatable. So it's in that sort of watch this space at this point. But it's very exciting times that there might actually be something that is available as a routine screen. So there's some things that you might have seen. But now I'll bring back to Emma to talk a bit about cancer genetic counselling.
Thanks, Sally. So what are some indications for cancer genetic counselling? And I guess one of the most obvious things is when you're asking a patient, has there been a history of cancer, and they're recalling multiple relatives have been affected, and if the relatives have had either the same type of cancer or similar types of cancer. Young age of onset is obviously a big red flag as well. Most of the older onset cases of cancer we typically put down to age. Those people have been around long enough to have age-related, DNA damage, a lot of time for environmental exposures and things. So usually older age onset diagnoses aren't considered as the younger ones. Individuals who have had a lot of polyps in the bowel, that's a big concern. And then some of the rarer tumours, there's a specific list on Eviq if anyone has any concerns about a particular patient. And a big thing within the BRCA genetic testing space is that the population frequency for a BRCA mutation for an average individual is 1 in 500. If you're of Jewish ancestry, it's 1 in 40. So anyone who's got Jewish ancestry and has a family history should be offered genetic testing straight away. So I'll just show you what we do in the background of how we assess. I've chosen BRCA because it's the one that's most topical. Everyone's talking about it, everyone knows about it. This is a specific case, a lady I saw a couple of years ago. She was referred by her GP. She was well at the age of 60, but her GP had sort of pieced together a bit of a family history and had gone, hold on, you've had breast cancer at a young age and you had a mum with ovarian cancer and another auntie, I think it is. I'll show you the pedigree in a second. So if anyone's concerned about referring to our service, Eviq is an online resource that's freely accessible. You don't have to have a login or anything. It used to, so ignore that. They don't have that anymore. But you can go on and look up the referral criteria. Now these are the referral criteria that are related to breast cancer history. The ones that are highlighted in blue are ones where individuals would automatically qualify for testing without any other factors necessary. The ones in black don't necessarily automatically qualify, but they should be referred so that we can fully assess the history. This particular lady shown here with the arrow, she had 2 well brothers, but you can see her mum had died of ovarian cancer. Her grandmother had died of breast cancer, and there's also an auntie who died of breast cancer. So when we assess a family history, we have to use a quantitative algorithm to basically provide evidence that there's enough of a chance of a BRCA mutation being identified to satisfy funding criteria. So Medicare's come on board since the end of last year to fund a lot of BRCA testing, and it doesn't quite cover all of the people we see, but the large majority. So I'll show you how we use the Manchester and the Bodicea. These are 2 of the programs we use to assess risk. And for Medicare to sign off on funding, we need to show that there's greater than a 10% chance of a BRCA mutation, and the testing has to be done in an individual who's had breast or ovarian cancer. We can't test, say, that lady's brother or her sister who's never had cancer, because you want to put your money where your highest hit rate could be, and that's in that person who's presented with cancer. So there's a Manchester scoring criteria, and that's on the Everq guidelines. There's also now an app by AstraZeneca that they've developed where it'll add it up for you. But basically, younger diagnoses get higher points. So you can see 38 someone in the 30s gets 8 points, someone in the 40s gets 6, someone in the 50s gets 4. That's for breast cancer. And ovarian cancer is very significantly weighted. Now, 10 to 15% of all ovarian cancers are due to BRCA1 or 2, so that is one exception where older onset cancer could still be related to a BRCA fault. So regardless of age, all ovarian cancers should get referred to our service. So we add all of that up, and there's sort of like a table at the bottom that says if it's a point range between this and this equates to this percentage chance. So her score equated to a 56% chance of a BRCA fault, so very clear that she qualified for testing. The other way you can do it is input the data into a specific software program, and it gives an exact risk for that patient. And coincidentally, this actually came out at exactly the same figure. So it's pretty robust. Both of the Manchester scoring system works pretty well, and it's a lot quicker to do it than this program. He's probably spent 15 minutes inputting all of the family history. So obviously in the appointment, we discussed the implications of testing for her in terms of what does that mean in terms of managing future risks, what could we potentially identify for your relatives, and the limitations of testing. If we don't identify a mutation, we'd still be concerned that there's some familial tendency to cancer. We still need to manage that appropriately. And obviously considering her psychosocial concerns or reactions to the information. Testing's obviously coordinated, takes unfortunately still a while even with current technology. And this was her result. So we did identify a BRCA1 mutation in this individual. And there's pretty clear guidelines around what to recommend to individuals, and that's pretty consistent with UK guidelines. Similar to America, they're a little bit more heavy on intervention, but it's pretty sort of international how women in this position are managed. Obviously, the biggest concern for this lady now was her high risk of ovarian cancer. Unfortunately, there's no effective screening for ovarian cancer, so we don't offer screening as an option, and we recommend that they consider risk-reducing salpingo oophorectomy. It's a very high uptake rate of over 95% of BRCA carriers for that, because they know that it's just not worth taking a chance with that cancer risk. Obviously, managing the breast cancer risk there's a bit more options available, and so that's, for women there's variability in terms of what they decide to do. Obviously, having risk-reducing mastectomy is the one that's going to bring your risk down the most significantly, but there's the option to choose tamoxifen to reduce the risk of breast cancer, and also just have more regular screening, so annual screening, and also before the age of 50 breast MRI. Part of our help is helping home, part of our role is to help patients make decisions about what they're going to do with regards to something like having your breasts removed. Can be quite a significant procedure, so women, it's important for them to think about that quite seriously and not rush the decision. So the outcome for this lady was that because she'd had breast cancer, she knew how difficult that particular time frame had been in her life. She didn't want to have a risk of going through breast cancer again, so she chose to have mastectomy of her other breast and the salpingo-oophorectomy. And then we provide support on how to inform relatives and see the relatives for testing, or facilitate that, whether they're sort of located elsewhere or statewide. We link them into the appropriate genetic service. We provide families with a letter that they can pass on that just sort of keeps it pretty simple, but says there's been a gene fault identified in the family. It's important that you seek your own information regarding this, and we can provide details of genetic services. One of the main frequently asked questions we get is, should men be considering having BRCA testing, because it's very much seen as a woman's concern, but it is still very important for the men to be having testing. They can be carriers and they can pass it on to their daughters. So if that information sort of is just dismissed by a male and potentially not passed on, it's just something that further down the line that information's lost, and their grandchild, say, may crop up in the future to have a young onset cancer. The men also are at increased risk of prostate and breast cancer, and so it's really important that they're aware of that, because the prostate cancers can be more aggressive and they need management, or annual screening with PSAs and digital rectal exams from their 40s. So that's one part of it. I'll just quickly touch on the fact that unfortunately there's not great awareness about familial bowel cancer, and yet it's actually even more common than the BRCA mutations. So as I said before, BRCA has a population frequency of 1 in 500. Lynch syndrome has a population frequency of 1 in 250 to 1 in 300 people. It's a familial predisposition to bowel cancer in men, and bowel, uterine and ovarian cancer in women. There's obviously very small risks for a few other cancers, but the most important screening relates to the bowel and having a hysterectomy for risk management for the ovaries and the uterus. If you've got any concerns, EviQ, as I said, is an excellent resource, and it goes into other rare conditions, renal, endocrine, other sort of conditions that I haven't been able to cover in this talk. So what does the future hold for genetic counselling? It's sort of hard to say. There's a lot more work going into very detailed genetic testing and doing genome-wide association studies to try and find genetic links for common diseases. And there's a lot of, in the commercial space, online, people are sort of being offered these tests where you can see if you're at slightly increased risk of developing dementia or, having cardiovascular disease. In the therapeutic space, there's genetic testing that can be specific to a tumour. So in ovarian cancer, they can do BRCA testing that an individual may not have inherited the BRCA fault, but they may actually have a BRCA fault within the tumour itself, and there's a treatment called a PARP inhibitor that they can respond quite well to. Obviously that applies for the BRCA carriers too. Pharmacogenetics is another space that there's a lot more commercial testing for. People are very much interested in epigenetics and the opportunity that we may be able to reverse or change disease outcome. Whole genome sequencing, I'll show you a slide next on how the cost of that's really come down. So rather than looking at single gene testing, whether it's cheaper and potentially provides more use, to just look at everything. But there's obviously more ethical concerns than when people may find incidental findings that weren't really the point of their initial referral. Obviously, as I mentioned, the ethical concerns, there's also insurance concerns for people, financial, psychological aspects of just finding out all of this overwhelming information, and some information that we actually don't know what we can do with at the time. They can find variants within a gene where it's not clear cut whether that actually has a disease effect or not, and that can create a lot of confusion for people. Obviously, as our field booms, there's not been enough genetic counsellors, unfortunately, so a lot of the services across New South Wales are understaffed, so hopefully there's going to be a little bit more of a push for more funding and also more education for people to be trained up to become genetic counsellors. This is what's called Moore's Law, where you look at sort of what's the cost of genetic sequencing back early 2000s and how significantly that's dropped right off in recent times. That was just a slide that's sort of related to where is our role going to take us. Is genetic testing going to become so accessible in sort of mainstream medical field that we'll be referred people once a result's identified rather than assessing them from start to finish? Will we be there as experts to interpret results? It's sort of hard to know where things are going to go. So just a quick summary on where you can go if you've got any questions about any genetic concerns about a patient. The Centre for Genetics Education's got really useful fact sheets on all different conditions and information for health professionals. The RACGP website's also got a lot of information, and they recently released for GPs, but I think it's very helpful just generally for a lot of the common genetic conditions, just what are sort of the key things that person needs to be aware of. Cancer, there's Evicue, which I've already harped on about. Prenatal has a service called Mother Safe, that's for people who are concerned about exposures during pregnancy. It's a quick phone call that you can provide just brief information and get advice on whether that's a concern or not. And there's also an online program for prenatal first trimester screening on the RACGP website. And if you've got any concerns, you're welcome to contact myself or Sally to directly ask us whether a patient needs to be referred to the service. That's it. Thank you. That one, we've got to record that one separately, do we? Is that just for this? They don't need to see it again, I've seen it, yeah.
This is about the NIPS test. Can I ask a question? I've just recently had twins, and I think during my pregnancy I was misinformed about the NIPS test and I'm not too sure, I haven't had any reliable. So they're fraternal twins, and I got told that if I got the NIPS test, it would be able to give me the result as to the trisomies, but it wouldn't be able to identify which twin had it. Is that correct?
That is
Yeah.
correct, yes. Because what it's doing is it's looking at fragments in the blood, and it would just be looking at the loading and look at the increase.
Because someone said that if they're fraternal, they can tell which twin.
You'd be able to differentiate maybe between the twins, but you wouldn't be able to tell which one it was.
No, that's true.
Like,
So yeah, I know. I just read somewhere else, but oh no, that's wrong. My friend's a genetic counselor or something, and they said that you could.
Maybe
I feel like you could tell between the two, but you wouldn't be able to tell which one it is.
Yeah,
It's not
unless you
left
have
and
it up
right.
with
or-
like Google,
yeah, you'd still have to.
translucency or whatever.
Yeah, but
Maybe a
you
combination.
indicator.
Yeah, so one of them has a trisomy and
If you
We'll follow
found
on
that
that
one
one.
had a trisomy, then what you'd have to do is do a prenatal test anyway.
Yeah.
So right, the CBSA and then nothing to do with that.
Yeah, okay.
I mean, they always have that worry about what does the
That'd be
baby
so
do
risky, yeah.
between that
Yep.
and then
It'd be huge.
into the
terminating
sequence.
one pregnancy though,
Hmm?
to terminating one pregnancy from twins
It's tricky.
is a complicated issue, isn't it?
Then
It
in
can
every
be done,
case,
but yeah.
it can be done, yeah.
I've got a big- and
But there is
No, 'cause-
significant risk of the other.
Okay, so it was right. that's
Never
right.
awesome.
Pretty awesome.
Thank you so much.
Was it pitched at what you were looking for?
No, that's
Yeah.
really
We
good.
weren't given any guidance of what to talk about.
Yeah, we didn't know whether you wanted very medical genetic stuff or just
No,
do an overview of.
I think that was really good, yeah.
Yeah, because it is becoming more pertinent, like patients ask about their genetic testing, that kind of thing, and you kind of, wow, I'm like, I don't know.
You're like, oh,
Yeah.
bad things.
Yeah.
Let me talk to you about that later.
Yeah, because we're looking, helping a little bit for like metastatic cutaneous SCC, they're doing genomic stuff.
Oh
with
yeah,
that,
with
at the uni.
yeah.
Yeah.
So
So I was like,
I'm
oh,
probably
this is quite
interested in
interesting.
who's doing